Preeclampsia is a disorder of pregnancy that affects both the mother and the fetus. It is an unpredictable and potentially life-threatening condition characterized by high blood pressure and the presence of protein in the urine.
Preeclampsia complicates 5 to 8% of all pregnancies and is a leading cause of maternal and fetal morbidity and mortality worldwide.
The disease can occur at any time, from 20 weeks of pregnancy right up to shortly after delivery.
As its name suggests, preeclampsia can develop into the life-threatening condition eclampsia, which, in addition to preeclampsia, is characterized by generalized convulsions that may lead to coma and death.
However, even if it does not advance to this stage, preeclampsia can lead to severe multi-organ systemic complications, such as HELLP syndrome or cerebrovascular bleeding, that by itself can be life-threatening. The diagnosis of preeclampsia is challenged by the fact that the two clinical features that define preeclampsia,
Elevated blood pressure and proteinuria,
can be quite unspecific, being linked with many other medical conditions.
The mechanism of preeclampsia is not perfectly understood.
However, it is proven that angiogenic factors play a significant role in the pathology.
In preeclamptic pregnancies, the placenta's blood flow from the spiral artery becomes restricted, reducing the supply of oxygen and nutrients to the placenta and causing it to become hypoxic.
In normal pregnancy, there is a moderate amount of the proangiogenic placental growth factor, or PLGF, present in the blood. PLGF facilitates vessel growth in the placenta, which is needed for the growing placenta supporting the growing needs of the fetus. PLGF binds to receptors called FMS-like tyrosine kinase 1, or FLT1, that are normally located at the wall of the endothelial cells of the placenta. In the bloodstream, there are small quantities of the soluble form of FLT1, also called soluble FLT1 or S-FLT.
Thus, there are normal levels of S-FLT and PLGF in the case of a normal pregnancy. In preeclampsia, elevated levels of soluble FLT are present. This means that more PLGF binds with the S-FLT in the blood, which reduces the amount of placental growth factor that makes its way to the receptors of the endothelium.
Due to the lack of sufficient PLGF, vasodilation does not occur in the spiral arteries, leading to insufficient blood perfusion and consequently reduced delivery of nutrients to the fetus.
Therefore, in the case of preeclampsia, a higher than usual level of S-FLT and a lower than usual level of PLGF can be analyzed in the serum.
These two angiogenic factors are used as biomarkers in the aid of diagnosis of preeclampsia. In a healthy pregnancy, the proangiogenic PLGF are stronger in the first and second trimesters than towards the end of the pregnancy. By contrast, in a preeclamptic pregnancy, we observe an imbalance in circulating PLGF and S-FLT1 towards the anti-angiogenic S-FLT1.
The light green data points are the S-FLT1 values from women with no preeclampsia across the course of their pregnancies,
whereas the dark green dots indicate the elevated level of S-FLT in women with preeclampsia.
The same goes for the placental growth factor, which is significantly reduced in women with preeclampsia. In order to identify those pregnant women that have elevated sFlt1 and reduced PLGF levels, the ratio between the sFlt1 and PLGF values is calculated.
The ratio of sFlt1 to PLGF has been shown to be a better predictor of preeclampsia than either measure alone. Angiogenic factors are proven to play an important role in the pathogenesis of preeclampsia.
Elevated levels of the sFlt1 PLGF ratio clearly correlates with preeclampsia, and low levels of the sFlt1 PLGF ratio correlate with absence of preeclampsia. The preeclampsia ratio is an objective tool to help substantiate the suspicion of preeclampsia.